Hi, if you want to have happier patients or customers while being able to document that you don't make an error, then please listen in because that is exactly what I'm about to show you now. What I'm about to show you is an online tool which can be used by your customers, that is the patients and their loved ones, and by your doctors to make sure that you don't commit an error and give them overview of where they are. First of all, we can hard code the selection of countries. I've chosen the UK here, but it can also be the US, Canada, Brazil, and a lot of other countries. I've chosen the UK here, and it will produce a flow that follows the treatment or the patient as the treatment goes on for breast cancer. And it will guide you all the way through so that you can at any time see what you have to go through and what you have gone through already. And then if everybody uses the tool, it will make sure that there is no error committed. So for instance, when you get to that crucial point, decision on kind of surgery, we can see that the tool will recommend that you have lumpectomy, which is a breast cancer surgery concerning the breast, as opposed to mastectomy, which is the other option. The tool recommends a mastectomy if you should have that, and then you can document what the patient eventually chooses: lumpectomy as recommended and chosen, or mastectomy, and then the patient will get a lot of documentation all the way through. But this is what I would like to show you. You can exit the presentation at any point in time, so I strive to show the most important things first, and then come back to the more detailed points later. So first, I would like to show you how it is possible to make it to show the whole treatment so that the guidelines are enforced. So a breast cancer treatment, right after the diagnosis, the doctor has to make the following decisions. Right after the diagnosis, the doctor, he or she, I'll say he, has to determine the stage and the prognosis. Then he has to decide whether the medication comes before the surgery or after. Then he needs to establish which receptors are positive or negative, mainly the estrogen receptor and the HER2 receptor, because they determine the treatment very much. Then whether the lymph nodes are involved, and if so, if there are any metastases. Then there's genetic counseling to be done, which is to determine whether the patient has an elevated risk, which will mean that another path of the treatment must be followed. For instance, if the BRCA test is positive, then the patient has an elevated risk. Or if a family, if there is a lot of breast cancer occurring in the family, running in the family, then the risk is elevated because there's a so-called hereditary risk somehow. Anyway, then he has to establish the tumor biopsy and do a genomic testing to see if the tumor is aggressive or not. And then a priori decisions about what the adjuvant treatment must be. Will she have endocrine treatment, which is the case for ER-positive tumors? Will she have chemotherapy, which is the case for high risk and HER2-positive tumors? It will last 3 months approximately, whereas the endocrine treatment will last for 5 to 10 years after the surgery. Then there's the trastuzumab, which must be given together with chemotherapy if it's HER2 positive. And finally, there's a radiotherapy that might come into question. Then he or she can start the treatment, which will include, if he has decided to give the medications first, it will start with the medications, the so-called neoadjuvant treatment, then surgery, which is either mastectomy or lumpectomy, breast-conserving surgery for lumpectomy, or removal of the whole breast, mastectomy. Then there's a lymph node assessment, which comes final after the surgery. And if there are lymph nodes involved in the cancer, then they must be cleared. And then there's a sample of the tumor sent to further analysis. And the analysis of the tumor will determine a lot of the treatment. It is histologically examined, that is under a microscope, and with a lot of classical analysis going on, and then genomically analyzed in order to find out if it is aggressive, and there's a bit of overlap between the two. And then that finally determines the adjuvant treatment, which can be a combination of the endocrine, the chemotherapy, the trastuzumab therapy, and the radiotherapy. And finally, there's a lot of follow-up. So all of this must be determined for breast cancer. And the demands for a tool like ours is to be able to map out that whole wealth of things to determine or decisions to be made. And the thing is that in order to do that, you must combine a complex problem with a complex solution, because a cancer treatment is one that has approximately 300 independent decision variables and 250 steps to undertake. And that combination puts the workflow that supports the cancer treatment in the upper right quadrant called treatment in this diagram. And that's what is new in this tool, the fact that we can have it supported by a workflow tool, given that it has so many independent problem describing variables, 300, and so many steps, and the whole thing might change while you undertake the workflow. That means the 300 decisions variables will be changed or known during the 250 treatment steps. And that is something that is quite new and hasn't been done before. That means that for a breast cancer treatment, you have to go through the blue arrows here, and the green decision variables will determine which blue arrows become relevant. And that is an example of a 300, 250 workflow in that quadrant. The thing is it a woman or a man? Can be a man. 1% of the breast cancers are men, and 99% are women. If it's a woman, is she menopausal or not? Is she pregnant? Is she old or young? Did she have radiation therapy in the past? Because if she had, she can't have it again, and that might determine a lot of treatment options that don't require radiation therapy. Does she have a family risk? Does she have drug allergies? What are her preferences? Is the cancer big or small? Is it a single or a multiple location cancer? Is it invasive or not? Is it ductal or lobular? If it's a breast cancer, which grade is it? 1, 2, or 3? Is it ER positive? Is it HER2 positive? Are the lymph nodes hit? These are just examples of the 300 decision variables that you have to determine, which will make, in that particular combination, which is the case here, will determine what the treatment path is. So the Cure GPS, or the tool that I'm presenting, will hold all these many variants, and that's because the underlying software, which I'll present in a moment, grows linearly with these many variant conditions. and that's why we can hold them, because we don't have a complexity growing problem. It represents the solution as a project plan, so it will be mapped out like you're used to as a project, a treatment project in this case. And just be reminded that the problem may change as you try to solve it, meaning that some of the variables like her weight, for instance, might change during treatment, and that means certain things have to change as well. If you determine a breast cancer treatment, the general things to pay notice to are shown in the green part of this matrix. For instance, the new adjuvant treatment comes into question if it's a large tumor. That's why we have this combination of Y here underneath large. Lumpectomy or mastectomy have to wait for new adjuvant treatment if it's there. So the predecessors are one for both of them. They are mutually exclusive, of course, and that means if there's a family risk, then you have to undergo mastectomy. Otherwise, you might consider lumpectomy. It's a little simplified. There are a lot of other questions to be noted. So the Y and N are here to notify that the lumpectomy is there if you don't have family risk. N for no. In which case you have that, and when you do or carry out the lumpectomy, you establish how many lymph nodes are hit, and you set whether it's a breast conserving surgery, because it is if it's a lumpectomy. You have to choose mastectomy if it's either large or there is a family risk, and then you set the number of lymph nodes. The lymph node surgery is there if the lymph nodes are hit, and they have to wait for 2 or 3, which we denote as 2, 3, because one of them is not there. So if we wait for both, then we only have to wait for the relevant one, number 2 or number 3. Then comes all the subsequent phase, the so-called adjuvant phase, as you see in the diagram here, which contains tamoxifen if she is premenopausal and ER positive, the tumor is ER positive. Whereas she would have aromatase inhibitors followed by bone loss treatment if she's not premenopausal and ER positive. So either of those two if she's ER positive. She will have chemotherapy if it's large, and there's a complex relation. So I will not talk a lot about the ands and ors in this, but we can handle them in the tool. But she might be premenopausal, which will, in some cases, in most cases, mean that she must have chemotherapy because she has it at a young age. If she's or the cancer is HER2 positive, she must have chemotherapy as well, which is also the case for trastuzumab, which she must have if it's HER2 positive. So there's a Y underneath HER2 positive. If the recurrence score is low, coming from the genomic test, she can omit chemotherapy in some cases, not if it's HER2 positive. And if the lymph nodes are positive, she must have chemotherapy. And trastuzumab I've dealt with must be there if it's HER2 positive. And you can see in the predecessors that chemotherapy and trastuzumab just have to wait for number 4, which is the surgeries, the lymph node surgery. And if it's not there, it means that the 4 means that it also has to wait for all the predecessors, which are lumpectomy or mastectomy. So 4 is sufficient to write. And that's chemotherapy and trastuzumab. Problem with trastuzumab is it must wait for some of the chemotherapy, and that's why the 7 is noted there, in that if there's a certain agent involved in the chemotherapy, which is typically given first in that 3-agent combination, then trastuzumab must wait for that first agent to be given 100% until it can start. So that's why we have a 7 here. And the radiotherapy comes into play if there are positive lymph nodes or if it's a breast conserving surgery. And it has to wait for number 7, it has to wait for the chemotherapy to be completed. So this whole matrix establishes the main configuration of the treatment, which you have to handle in that tool and which an oncologist has in his or her head. So the tool must be able to handle this complexity and everything that lies beneath it. And that's when we introduce the so-called process matrix. It can be simply understood if you liken it to the same flowchart, which would be inhibitively complex when it undertakes a cancer treatment, but it's easier to show now in order to explain what a process matrix is. These two diagrams are the same. So if there are 3 activities, paraclinics, surgery, and medical, and you have to decide whether you have surgery or whether you have the medical treatment, which is what you see here, that's also depicted in the process matrix. And you saw the green areas which will determine which variant you are in or you have to have in that specific case. The further comparison is here, which is still the same flowchart with forms and the similar process matrix underneath it. So the final thing is that as long as it is a simple workflow, you can depict it as a flowchart or as a process matrix. The benefit of the process matrix is, however, that it doesn't grow exponentially with the complexity of the workflow. So if you undertake to map the breast cancer treatment, you must do it in a process matrix format, and you can see that it has 250 activities, some of which are shown here, and they are in rows. One row represents one activity. The decisions you have to make are the green columns out facing the rows. So if there are 300 decisions to be made, there must be 300 columns only. And the data elements are depicted to the right, and they make sure that you can build forms and make relevance rules or recommendation rules for instance, which surgery type you recommend. And actually, in order to recommend either mastectomy or lumpectomy, you have to determine a lot of variables, one of which is the family history. You can see it here, but there are a lot of other variables that determine whether you recommend a mastectomy or a lumpectomy. And all of this is, all these rules are also in the matrix. So the process matrix is a complex format, or a very compressed format that will enable us to hold a very complex solution and a complex problem in the same format. And if you look into the wealth of the breast cancer solution is depicted here in headlines. We'll take a few headlines out just to show you how they are handled by this process matrix and the tool that runs on top of it. So if we start with one, the BRCA or family history headline, it's here, and you can see that it implements a form that helps us determine whether there's an elevated risk of breast cancer, in which case the lady must have mastectomy, and there's a wealth of other things that you have to do if she has an elevated risk. In order to determine that, if there's a BRCA test, it's quite easy. You have an elevated risk. If there's no BRCA test or it's negative, then you have to look at the family. And the example we have shown here is that if the mother had breast cancer at the age of 38, then there's an elevated risk. And the thing is, there might be a lot of other combinations, like your mother was 42, but her sister had breast cancer as well. Then another rule will be flagged to say, okay, two family members had breast cancer at a younger age than 50, in which case you have an elevated hereditary or family risk as well. So that's just one step of the whole flow in that determination. The tumor characteristics typically comes from the mammography, and then it must be keyed into the solution, and from that it derives what the T classification is. Then there's that decision about which kind of surgery you would want to have, and that depends on whether you had radiation before, because in that case you can't have it again, and if you can't have it again, you must have a mastectomy, because that's the only option that doesn't require a radiation. But if you didn't have radiation before, then if your tumor is well delineated, if there's enough tissue around it in the breast, etc., then you can have a breast conserving surgery, provided again you don't have a family history of breast cancer or an elevated genetic risk. And then we record that recommendation, which is correct and in conformance with the guidelines, and we record what the patient subsequently chooses to have. In this case, she chooses to have a lumpectomy as recommended. And then there's a lot of documentation which the tool produces in order to tell the patient or the relatives what is the background of the recommendation. Then finally, the tool also determines whether the tumor means is big enough or in other means risky enough to have medication before the surgery, so-called neoadjuvant treatment, or will operate right away and give the medication afterwards. That's the so-called adjuvant treatment. That's just one thing the tool does. Then it configures the adjuvant treatment. All in all, the chemotherapy, radiotherapy, we don't have trastuzumab in this particular case that I'm showing because it's HER2 negative, and the hormone therapy because it's ER positive. And the way it does that is it allows the pathology report to be keyed in and derives the logic it can derive from that report, and that will determine how ER positive it is, whether it's HER2 positive or negative, what the grade is, etc. Then it handles the gene tests if you are eligible to have it. It will have logic for Oncotype DX or Prosigna or PAM50, and in the future others. And that will establish whether a chemotherapy comes into play. In this particular case, the recurrence score is such that the chemotherapy is advised. Then if the chemotherapy is advised and furthermore chosen, then it will do a further recommendation. In this case, it's HER2 negative, so trastuzumab or Herceptin is not offered. And finally, it will advise about the radiotherapy. Furthermore, it calculates the dates, and thereby is able to present a treatment plan, which can change. And in this case, the surgery will be the October the 31st, and then it derives that the chemotherapy must start on the 22nd of November, because it has to wait for a certain period, 21 days after the surgery, and then it takes it lasts for 126 days, so it ends by March the 28th next year, and that's the date. March the 28th is the date when tamoxifen treatment for 10 years can start, and radiation therapy can start. It lasts 35 days, which is a month or so. And then it goes on. The whole thing is that the tool will make sure that everything is decided correctly and documented. And so the EHR or the data that it builds on can be taken from or given to, or both, to the electronic health record. I'll just show you a few screenshots showing what amount of data it works on and produces or reads, or both. And there are a few screenshots here, and I'll just browse through them to give you an impression of the wealth of data that it produces. Here, the chemotherapy combination and other medication data as well. And finally, the radiation data at the end of this will come up here, and it will produce the input to how you do the radiation treatment and a lot more. So if you adopt this tool, it will help her and her relatives, or him if it's a male cancer, understand the treatment and follow it all the way through, maybe several years through. But it will also make him or the doctor able to document that every decision is correct in this whole treatment path. And that is be reminded about 300 decisions that are correct, and you can document that they are correct. And the way we document that is that every recommendation has a rule behind it, and you can see it highlighted here in red. For instance, if we recommend a lumpectomy, we have a rule that informs us how that is recommended. And all the data is recorded and timestamped as well, so you can see exactly when that data came in. And when you made the decision, you can establish what the data was up to that point in time, and document then that the rule behind the recommendation you gave was in conformance given the data you had at that time. So this is what we now have as an opportunity to do in many countries, maybe the whole world, show the guidelines and be conformant to the guidelines in that country. We've chosen UK here, but it can be many other cases as well. And then, by the way, the whole thing was shown in English, but we can show it in a lot of other languages as well. So given that we have chosen the UK as a rule base, we can still show it to the Danish family, or the Norwegian family, or the French family, or the Spanish family, or East Asian families as well. They will look at the same amount of data or the same project, but in their own language. And thereby, I hope that you agree with me that we can actually get happier patients, and at the same time document that we don't make an error. Hope you enjoyed it, and we hope very much to cooperate in the future so that we make it possible for your patients to enjoy this benefit, and your doctors and your hospitals to save the money associated with being able to document that you don't make an error. Thank you for listening.